Greetings and welcome to another Oral Pathology Tuesdays on OP360 channel. This is where we get together every week in a live stream to discuss matters that relate to oral and maxillofacial diagnostics, whether it is oral pathology, oral medicine, or oral radiology, as we have today. It's really great to have everyone with us. And just to start and to go on, first let me say I'm Dr. Mandana Donahue. In case this is your first time, I'm the founder, director of Oral Pathology 360. And whether it's your first time or you have been here before with us, well, welcome. We have a few announcements before we go on. So, first and foremost, let me welcome our new member, Nagihan, or if I have correctly said that. And if you're wondering what the membership is about, as you're watching the video, you can see below, besides the subscribe, there is also a join button. If you click on that, there are three tiers of memberships. Each one for a small amount that you pay every month will help us in doing the things that we do and continue to make the content that you love. Although, please remember and please be sure that the content that is free will always remain free and will always be as good. And of course, also, if you have not subscribed, please hit subscribe right there. And you may know that we just finished our conference at the International Oral Diseases Case Presentation Conference. So, this seems like a good time to just have a short review of what happened. So, if you were with us for this one, thank you. And we do hope you enjoyed yourself. If you went with us for this one, please join us in the next one. That's in 2025. It will be around the same time, either in the first week of May or the last week of April. Now, coming to today's lecture, first, let me tell you that as you may know, we have other content on the channel that is oral medicine. There are quite a few, but I also found that we have already some oral radiology, and I have kept them here. There is a whole playlist now for oral radiology, and you can find these wonderful lectures and watch them afterwards. Coming to today's lecture, and let me bring in our guest. Dr. Deepak Gupta is with us. Welcome.
Hello, ma'am. Thank you, ma'am. Thank you for inviting me here. Thank you so
You're
much.
most
I
welcome.
would say that it takes a lot of hard work for make some ideas work, and you have done it. You are doing great job, and it is definitely inspiring a lot of young minds, I would say. So thank you so much for having me here.
Thank you so much. And talking about inspiring young minds, let me also tell everybody that Dr. Gupta is another person I have found on LinkedIn. Maybe some years back we found each other, but nonetheless, it was again thanks to LinkedIn. So I
Great.
was even a part of, or rather contributed to, an edition of a journal that he was editing and he put together. And that's how we met. So, like I always tell all of you, especially the youngsters, please get on LinkedIn, get to know people. It really makes a difference. You will find some of the
Great.
most wonderful
Definitely.
people you will meet on LinkedIn, professionally, anyways.
True.
And
True.
also, let me just say that I forgot Dr. Gupta is the professor and head of the Department of Oral Medicine and Radiology at MMCDSR, Maulana Ambala, India. And yes, it's great to have him with us. and he is going to be talking about CBCT. As you have seen, I think it's a topic he is very fond of. Yes, Dr. Gupta, anything you want to say before we move on? No, okay. Let's play the lecture and then come back.
A very good afternoon to all present. This is Dr. Deepak Gupta. I'm an oral medicine and maxillofacial radiologist. First of all, I would like to thank Dr. Manna and her team for having me here and giving me a chance to interact with you all. It is indeed a very unique kind of platform. Hats off to ma'am for making this practically possible. I surely know that this platform is very beneficial for the students as well as practitioners. The topic of my presentation today is nothing new. It is on CBCT and its fundamental along with its applications. We must be discussing all this, but before that, I would like to bring to your attention a very important yet neglected field regarding the same. We all are dental professionals. And what do we exactly deal with? We deal with diagnosis and treatment planning of our cases. And what is most crucial in diagnosis and treatment planning? Indeed, our hard work, dedication, and knowledge counts. But yes, we need radiological evaluation of our cases. So we can say that radiology is considered as an integral part of our dental treatment. Now, there are several kinds of radiographic practices which are followed by practitioners on day-to-day basis. Some people get an OPG done, some get an IOPA done, some go for specialized imaging modalities like CBCT and CT. What is common in all this? We need X radiation to capture these radiographs. So common is X radiation. Otherwise, radiation is everywhere. We are actually living in a sea of radiation. Radiation is there coming from sun in the form of cosmic rays. It's present in the air which we inhale in the form of radon. It's present inside our own bodies, plants. So this all is natural and background radiation, which constitutes almost 87% of the radiation exposure falling on human body. A part of this natural background radiation, there is artificial background radiation which is man-made, out of which a major chunk, that is 12%, is constituted by medical and dental diagnostic radiations. That is why we need to keep a check on this, because X-rays are harmful. Now, if enough cells are killed in an individual due to this radiation exposure, it may cause injury or death. While if the cells are modified, such changes may lead to cancer or disorders in the descendants of exposed individuals. Such effects are known as stochastic effects because these effects are not dose dependent. They say that every exposure to ionizing radiation, please note this point, that even a single exposure to intraoral periapical radiograph carries with it the possibility of inducing a stochastic effect. That means there is practically no safe dose below which these effects do not develop. And the examples of these effects may include leukemia, certain tumors, radiation-induced cancers, mutations, congenital abnormalities, and so on. So that is why it becomes utmost important to keep a check on unwanted usage of these radiation exposures. A recent research which was done in dentomaxillofacial radiology also reveals that the partial or total CBCT scans, when done on patients, they promoted induction of certain cytotoxic nuclear alterations even after a single exposure. And these nuclear alterations included pycnosis, micronucleus formation, karyohexes, karyolysis, and so on. So we must follow ALARA principle, which means that we should avoid unnecessary exposure to radiation that does not have a direct benefit to the mankind. We must take a pledge that not all patients actually require a CBCT scan or 3D imaging, and it should not be used on a routine basis for screening purposes on all individuals. With this note, I would like to start the topic on Cone Beam Computed Tomography. What is the problem in this image? You can easily see that on the rear image, the right side of the hand is superimposed, while on the image on the right side, this left hand is superimposed. Now that is what is the limitation of 2D system, that there is superimposition of anatomical landmarks and there is lack of differentiation of object thickness, width and density when a 3D structure is visualized in a 2D system. You can easily see that in 2D shapes you cannot appreciate width, while in 3D shapes Definitely length, width and height is there. As far as history of CBCT is concerned, I would like to give the credit to Sir Willem Conrad Röntgen, who actually discovered X-rays in 1895. Without the discovery of X-rays, this would not have been possible to capture any kind of radiographic imaging modality. Later, CT was invented in 1972 by Sir Godfrey Hausenfeld and Alan Cormack, and they also received a Nobel Prize for the same. This is the picture of the first clinical CT scanner, which was installed in between 1974 and 76. This first CT scanner was developed by Hausenfeld, and it took several hours to acquire that raw data. This later technology transfer of CBCT to dentistry first occurred in 1995, and the credit goes to Tacconi A and Pyromozo. They developed a CBCT system for maxillofacial region in Italy. The first unit was Newton DVT 9000, which became first commercially available CBCT unit in the European market. These are the pictures of the first two commercially available CBCT units in United States, Newton DVT 9000 and 3D Acute. Now, what is the principle of CBCT imaging? A CBCT machine basically has a rotating gantry. This is the rotating gantry of the CBCT machine. In this, on one side is the X-ray source, while on the other side is the detector. So the patient stands here in this machine, and this rotating gantry rotates around the region of interest. The X-ray tube and 2D detector system, which is part of the gantry, they rotate around the patient's region of interest, which leads to sequential exposures of the patient's area and production of raw data, which is known as basis images, which is the result of sequential exposures. Later, software algorithm is applied, which leads to production of image reconstructed data or 3D data set, which is further converted into orthogonal planes as a part of secondary reconstruction. So this is what is the principle of CBCT imaging. Now, CBCT image constitutes of different shades of gray. Certain structures are whiter or lighter, while certain structures are more darker. So this is because the patient is exposed to ionizing radiation and the beam passes through tissues of varying densities in a subject. So high density objects, they attenuate the X-ray beam more as compared to low density objects, which results in reduction in the number of X-ray photons which strike the detector when they pass through high density objects. This difference in the densities which is received by the detector is registered on the detector in the form of a formula or algorithm for each attenuation. This results in a numerical matrix of assigned value to each location, which is actually displayed on the monitor as an image of varying shade of gray. So high density structures, they appear white or light in the image, while low density structures, since they absorb very little X-ray beam, they are appeared as dark or black. Now, there are certain considerations which one should consider before purchasing a unit. According to this, the CBCT units can be categorized into patient positioning, field of view, clinical functionality, and detector type. As far as field of view is concerned, it is that anatomical area which is actually included in the data volume. So accordingly, basically, there are three types of fields of view, that is small, medium, and large, which comes on in different sizes in different CBCT machines. Moreover, small FOV is actually used for endodontic purposes. The reason is, since the FOV is smaller, its resolution is more. So it is more better to visualize changes in the PDL or lamina dura. It is more better to visualize root fractures, periapical lesions, root canal morphologies, canals, and so on. While medium FOVs, they can shoot an arch or both arches and is approximately 6 to 11 centimeters in height. It helps in the evaluation of the extent of lesion or status of temporomandibular joint. It also helps in implant panning as well. While the larger FOV machines are recommended for cases which are actually surgical or are having skeletal abnormalities, it extends from the inferior border of the mandible to the vertex of skulls. So more is FOV, more expensive the machine becomes. So it's important to know that we should request small FOVs in case we need to avoid unnecessary radiation exposure to the patient, and also in case we order small FOVs, spatial resolution of the image will increase. As far as choice of detector is concerned, it is directly related to price of the unit again. More bigger is the size of detector, more expensive the unit becomes. Initially, flat panel detectors were not available. Initially, image intensifiers were available, but since they were bulkier and they were not able to eliminate geometrical distortion, the image was not very good. Nowadays, we have flat panel detectors. They are of two types, direct and indirect. The details of these detectors is not in the scope of this particular lecture, but more recently CMOS detector systems, charge complementary metal oxide semiconductors, are used. They have got a very large FOV and have got very fine resolution. Now, what is a voxel? A voxel is the smallest unit of a CBCT image. It is the smallest 3D element and is constituted by height, width and depth. Like a JPG image, in case you zoom out this particular picture, you will see that this particular image is constituted of small squares. The smaller is the size of that square, more better resolution the image gets. So similarly, a CBCT image is made up of voxels. More smaller is the voxel, more better image quality and resolution becomes. So CBCT machines comes with different voxel sizes. In case we use small field of view, they use a voxel size of 0.076 millimeters, which actually enables the visualization of very small structures. So a take-home message is, in case we are evaluating a patient for a tooth fracture and somebody gets a CBCT scan done, he should always advise for smaller FOV because it will lead to more better resolution and more better clarity in the image. Larger the voxel size, less the resolution will be. So voxel size needs to be smaller than the desired anatomical structure for adequate representation. In case the voxel size of the machine which we have chosen is bigger, it will not be able to appreciate smaller things like small cracks in enamel. You can easily appreciate here that as the voxel size increases, the clarity of CBCT image decreases. Further, CBCT provides several display modes apart from basic orthogonal views that can be oblique slicing, curved slicing, cross-sectional views and so on. The details of these all slicing and modes is not in the scope of this particular topic at the moment. Now, CBCT carries great advantage over CT. Reason is the CT has got high radiation dose, it is more expensive, its availability is not that easy, it has got longer scanning time, while on the contrary CBCT reduces unnecessary exposure to the patient and thus minimizes scattered radiation. So that is why CBCT becomes the choice of dentists for implant planning and other treatment modalities. Now CBCT also comes with an artifact reduction software. You can easily appreciate here that in this picture there is artifact present due to metal fillings, while in this picture artifact is not there. So these days CBCT machines, they come with inbuilt artifact reduction softwares as well. Nothing comes without limitations. CBCT has got limitations also because it is not able to record soft tissues in much better way as compared to CT, while further there are certain artifacts, noise and poor soft tissue contrast as well. Now this is important to know that there are certain reference planes on a CBCT image. The first reference plane is axial. This reference plane is actually transverse and is parallel to the floor. Here you can see that you can evaluate the patient, or you can evaluate the image antero-posteriorly and buccolingually, but it will not give you any dimension superior-inferiorly. This is the coronal plane. This image is the coronal image of the CBCT scan. This coronal plane is parallel to the coronal suture, and again this will help us to evaluate superior inferiorly and buccolingually, but it will not give you the dimension antero-posteriorly. Similarly, this is the sagittal plane, which is parallel to the sagittal suture. It slices through front to back. Here we are able to evaluate the things antero-posteriorly and superior-inferiorly, while it will not give you any dimension on buccolingual direction. Now let's discuss the applications of CBCT in dentistry. This boy is a case of trauma, and you can see that there is intrusion of the teeth. When 2D imaging modality was done here, you can see Ellis class 2 and Ellis class 3 fracture on 1-1 and 2-1 respectively, while the patient was also subjected to CBCT, and when CBCT was done, we can easily appreciate intrusion of the tooth along with fracture at the nasal floor in both the teeth. This is indirect volume rendering or 3D image of the patient where you can appreciate the apex of both 1-1 and 2-1, which is projected inside the nail cavity. So CBCT sometimes gives us a third eye for the diagnostic aspects. Henceforth, applications of CBCT are there in almost each and every field of dentistry. Now let's discuss the role of CBCT in implant dentistry. Nice picture, bread and butter, right? Initially, years back, we used to say that restorative treatment is actually considered to be bread and butter in dentistry, and our mentors used to say like this. But nowadays, I feel that the scenario is quite changed. With the evolution of dentistry and mindset of patients, I would like to say that now implants are also considered as bread and butter in dentistry. Patients come and ask for implants now. So dentists are either doing it themselves or they are calling some specialists for the same. But in this flow, everybody has forgot the big learning curve which is actually involved in implants, especially the treatment planning. So what is the result sometimes? The result is sometimes like this, or even this. That is failure of implants. It's fine in case the complications are like this, post-operative. These depends upon the skill of dentist while doing osteotomies, and they will sooner or later learn and they will get a second chance. But what if the complications are like this? These are very disheartening. And what happens in case these complications happens to a dentist that has recently started doing implants? It will be very frightening and disheartening. And most of these intraoperative complications happen due to the result of arterial trauma or perforation of the lingual cortical plate. The reason is improper evaluation or treatment planning on a CBCT image. So these intraoperative complications happen due to improper angulations or improper position, which leads to bleeding, cortical plate perforation, neurosensory disturbances, and so on. So a proper evaluation of a dental implant patient on CBCT is very much required. Now, what is most desirable by a clinician who is doing implants? After the placement of implants, the most desirable is a very good prosthesis. A thorough analysis of the anatomy of residual alveolar ridge and evaluation of bone density is what is required. So what a CBCT scan can offer us? Definitely CBCT scan can offer us evaluation of bone dimensions like height, width, bone quality. It also helps to identify and localize internal anatomy, jaw boundaries, and to detect any underlying pathology. As far as bone height is concerned, it is measured from the crest of alveolar ridge to the opposing border of the bone or any anatomical structure. Anatomical structure, in case it is mandible, then it is upper border of inferior lower canal in the posterior region, while it is maxillary sinus lining in the upper posteriors. It is nasal floor in case of maxillary anteriors. And then it also helps to evaluate bone width. Bone width is the buccolingual width of the alveolar bone, and implant diameter is selected on the basis of this bone width. Sometimes there is thin crestal ridge, and here the crestal ridge is reduced to increase the recipient bed for implants for implant evaluation. Length of edentulous segment is also a very important parameter to be considered while reporting a CBCT. Sometimes we place an implant inside the patient, and later when it's time to prosthetically rehabilitate that patient, we see that there is not enough space for the crown of that patient, or in case it's anterior, there is more space as compared to the opposite side. So it leads to problems. So evaluation of length of edentulous segment becomes an aspect of paramount importance. In case the length is less than 6 or greater than 13 millimeters, that is in case the edentulous segment is EJS type 3, then it becomes practically impossible to install one or two proper implants. The reason is we have to keep a minimum distance of 3 millimeters between two implants, and the distance between an implant and natural root should be at least 1.5 millimeters. So according to this, it becomes practically impossible for edentulous segment type 3 to rehabilitate with proper implant planning. What is alveolar ridge vertical position? Sometimes in case a missing tooth is present since long, then it lead to resorption of the alveolar bone like this. So the distance between the lowest point of the alveolar ridge crest to the cervico-enamel line of the adjacent teeth is known as alveolar ridge vertical position. This parameter is important for achieving favorable implant crown length ratio and for aesthetic results. What is the desired prosthesis? We have already discussed that to ensure optimal aesthetic rehabilitation, implant supposed restoration should be exactly equal to or in symmetry with the adjacent dentition. See in this photograph, this particular patient had implant in 2-1 region and the crown of 2-1 and 1-1 is almost symmetrical. Now, if the patient has greater width of the edentulous span as compared to the opposite side and the patient wants good aesthetic result, at that time orthodontic treatment for the edentulous segment or some other treatment modality may be required. Evaluation of bone density is also a very important aspect in CBCT planning. Ideally, bone density is evaluated with the help of Hausenfeld units in CT machine, while CBCT is not able to evaluate bone density in Hausenfeld units. Now, actually, Hausenfeld units is the degree of X-ray attenuation by the tissues, and CT is actually able to calibrate this by taking reference density values of air and water. However, in CBCT, it is not possible because CBCT machine is not calibrated by reference density values of air and water. In CBCT, the degree of X attenuation, X-ray attenuation is shown by grayscale values. So that is why it is said that Hausenfeld units cannot be written while reporting CBCT. This can be a disadvantage of CBCT, while many other studies have shown that there exists a linear relationship between Hausenfeld values of a CT scan and grayscale value of CBCT. This suggests that voxel values of CBCT can be used for estimation of bone density. So that is why we use this particular classification for bone density evaluation in CBCT, according to which the bone density is classified into 5 types on the basis of density of bone. It is also important to evaluate mandibular canal walls and jawbone quality for a good implant insertion. In case mandibular canal walls are visible and the patient is having D2 or D3 bone quality, there is very low risk of inferior nerve canal injury. While in case superior mandibular canal is not visible on a CBCT image and the patient is having D1 or D4 bone quality, there exists moderate risk for inferior nerve injury. On the contrary, in case when it is impossible to identify mandibular canal, that is superior as well as inferior walls of mandibular canal are not visible and the patient's bone quality is either D1 or D4, there exists a high risk for inferior nerve canal injury. You can appreciate this fact with the help of this CBCT picture. You cannot see the superior or inferior boundary of the mandibular nerve canal here. So there exists high risk for injury to the nerve canal while doing implants in such cases. Now there are certain anatomical structures inside the maxilla and mandible which should be taken care of while implant planning. It is nasopalatine canal in maxillary anterior region. Then it is the maxillary sinus region in maxillary posterior region. Then is the interforaminal region which has got mental foramen on both left and right sides. It should be taken care of. And definitely inferior lower canal in the mandibular posterior region. A part of implant dentistry, CBCT is used for several other areas as well. This also helps in the post-surgical assessment of bone grafts and post-operative assessment of implant position in the alveolus. It also helps for the preparation of surgical guides. This particular case required implant in 1/6 region, and when CBCT was done, it showed increased thickness and density of the tissues inside the maxillary sinus region, and there was communication, oroventral communication present in between the roots and the sinus lining. So CBCT becomes the diagnostic modality of choice while putting implants in such cases. In some patients, there is profuse bleeding while creating an osteotomy site for implant. This can be justified due to localized increase in vascularity of the mandible. You can see here that there is increased vascularity of the mandible present, and sometimes there is even bifurcation of the inferior dental canal present. Hence, for such cases, must be evaluated with the CBCT for these things. See here, the bifurcation of canal is present, which can lead to injury while putting an implant. As far as oral and maxillofacial surgery is concerned, CBCT is able to provide precise and exact measurements for surface distances. So it helps in the measurement, it helps in the evaluation of fracture cases, it helps for precise location and extension of pathologies as well. Pathologic calcifications like tonsilloliths, salivary gland stone can also be easily recognized with the help of CBCT. It also helps in the evaluation of unerupted or impacted supernumerary teeth and their association with vital structures. This is a case of trauma and it reveals evidence of fracture in the parasymphyseal region of the mandible. There is the axial slice which reveals fracture, and there is the indirect volume rendering or 3D image which shows fracture in the parasymphyseal region. This case shows dentoalveolar fracture which actually was not evident on 2D imaging. In this case, there is presence of cyalolith which is evident on the axial section of the CT image. There is a sagittal view again which shows the presence of cyalolith. This is a case which shows the evidence of Stephanie bone cyst which is present in the axial, cross-sectional or indirect volume rendering images. CBCT is also capable of evaluating the status of impacted mandibular third molars. You can see here that the status of impacted mandibular third molar and its correlation with the second molar and inferior alveolar nerve canal is clearly visible. These are the cross sections in which we can see that the tooth roots are away from the inferior alveolar nerve canal. This particular case presented with pain in the mandibular region, and the patient also had history of extraction. When there was no convincing facts found on a two-dimensional radiographic image, a CT was done, CBCT was done, which showed that there was iatrogenic injury or accidental sectioning of distal root of second molar. You can also see the sectioning of distal root of second molar present in this cross-sectional image. As far as orthodontics is concerned, CBCT provides superimposition-free images with a practical 1:1 ratio. Henceforth, in orthodontics, CBCT can be used for evaluation of palatal bone thickness, skeletal bone patterns, dental age estimation, visualization of impacted teeth, inclination of teeth, and so on. CBCT can also provide practical guides for safe placement of mini implants or evading accidental and irreparable injury to vital structures. CBCT also serves as an excellent imaging modality for evaluating TMJ disorders because it helps to examine joint space and the true position of condyle within the fossa, including the superior surface of the condyles. This is the TMJ joint which is evident on the sagittal and coronal section, and you can see how beautifully CBCT can depict the condyle joint space as well as the fossa. This case shows bifid condyle in the CBCT image. CBCT provides evaluation of degenerative changes in the condyle as well. Here you can see cyst formation, erosion as well as osteophyte formation on CBCT images. These are sagittal sections of CBCT image. In endodontics, CBCT can be used to determine the morphology of roots as well as associated canals, both accessory and main. It also helps to establish working lengths and determine the type and degree of root angulation. It helps us to classify the source of the lesion as endodontic and non-endodontic. Sometimes it becomes very difficult to treat such cases. So CBCT can be a third eye in these kind of cases, which may influence the treatment plan. It also detects root fractures and measures the depth of dentin fracture. But again, as I have intimated earlier, it's always better to shoot such scans at a smaller FOV. So it also helps to depict pulpal extensions in talon curves or localization of broken instruments. It provides three-dimensional evaluation of periapical pathology along with information of the canal morphology. Here you can see that periapical pathology is evident on CBCT. This is a periapical radiograph of an arterially treated tooth. It has periapical radiolucency present, but when CBCT scan was done, it shows missed distopalatal canal and periapical radiolucency was also evident. This case reveals the presence of exostosis here in this area. Further, this is a small FOV CBCT scan which shows MB2 canal here. It also shows the presence of pulp stone here in this section. This case presented with pain to the dentist, and when CBCT was done, we can see that there was evidence of periapical radiolucency at the apical region of the lateral incisor. However, the periapical radiolucency was not very well appreciated on an IOPA. Further, there was evidence of vertical root fracture which was visible on the sagittal section of the CBCT image. So CBCT helps in the diagnosis of such cases. CBCT has role and applications in periodontics as well. Literature has confirmed that the morphometric analysis of periodontal diseases by CBCT is actually as precise as if we are doing direct measurements with a periodontal probe. So CBCT aids in visualization of buccal and lingual defects. It helps in the precise measurement of intra-bony defects and lets clinicians to evaluate furcation involvement, dehiscence, fenestration, periodontal cyst, and post-surgical regenerative periodontal treatments. Here in this case, we can see that periodontal evaluation is very easy on CBCT scan. On this CBCT panoramic view, you can see that there is presence of horizontal bone loss, while the cross sections in CBCT helps in the evaluation of furcation involvement, as well as in this we can see the buccal and lingual cortical plate bone loss. Further, these 3D sections, which are known as indirect volume rendering, they can be used as a tool for educating the patients as well. CBCT also aids in virtual treatment planning as well, because the software which is available with CBCT images, it allows for virtual planning, which can be transferred to the surgical site either directly or by the use of image guided navigation softwares. This is a pro type of surgical guide which can be made with the help of STL files of CBCT. Mock surgeries are also possible with CBCT. It's an actual and dimensionally precise model of an anatomical structure which is produced using rapid prototyping. Now, when this actual and dimensionally precise model is created using the files of CBCT, it helps the practitioner with high level of confidence beforehand and lessen the surgical and anesthetic time with these models. CBCT is boon for ENT applications as well, because CBCT can easily depict the evaluation of paranasal air sinuses. You can see here on this axial scan how clearly maxillary sinuses is visible. This is the sagittal section which shows the relationship of the maxillary tooth with maxillary sinus. Further, CBCT can also help to evaluate deviated nasal septums towards the right or left side. So we can conclude that so far 2D imaging has actually assisted dentistry effectively and is actually bound to do so in near future as well. However, CBCT imaging surpassed the obstacles of 2D imaging, which we have already discussed, offering practitioners with high quality sub-millimeter resolution with shorter scanning time and low radiation dosage as compared to conventional CT scan. Since this equipment has become accompaniment of the dentist, dependence upon practice-based guess estimation will be replaced, benefiting both the patient and dentist. And actually, huge scope is still available for further applications and needs exploration from diagnosis to image guidance of dental procedures. Thank you so much. Thank you so much.
Yes. Thank you for that presentation. It was really nice and thorough. And I particularly liked the beginning where you spoke about Alara and about radiation, because that's really normally forgotten and
Yes.
not really sort of talked about as much as we should. So it was a good thing that you actually included that. Now, let's see any questions. Let our audience put in their questions. So I noticed you were included a lot about implants, about the use of CBCT in implants.
Absolutely.
How much do you use it for implants now?
Ma'am, actually, initially frankly, CBCT was not being used for implant planning. But nowadays, I would say CBCT evaluation is required for each and every case of implant. Because as I have already dictated that it's not only anatomical landmarks which are actually kept in mind, like inferior alveolar nerve or maxillary sinus. It is actually bifurcations or trifurcations of the nerve also, which obviously incidence is less, but there is a possibility. And then there are certain anatomical variations like some mandibular salivary and depressions or so many other things. So although incidence of these instances is less, but we cannot play with the patient. So I would suggest CBCT scans to be done in each and every case in case somebody is planning for implants. That's it. Although incidence of doing CBCTs for maxillary anterior region or mandibular anterior region are lesser, and I agree to the fact that somehow those areas can be managed. But still, research reveals that there are anatomical landmarks present and there are chances of problems. So, frankly, as an oral radiologist, I would say CBCT is a must for all cases, not just few cases.
True, and I think right now there are enough of the machine also is fairly easily available. I mean, it's there almost everywhere, I think.
And I think there is some problem with the internet connection. Probably my internet
You
connection is
cannot
not.
hear
Can,
me?
can you please? No, no.
Okay, no, I was saying that now the
Ah,
machine must be fairly easily available around.
yes, ma'am.
Access is there, yes. Okay, we have some questions. Let me bring those here. So, Dr. Muttu is asking the CBCT role in oral pathology.
Yes, ma'am. So, thank you, Dr. Mutu. This is actually a nice question. CBCT definitely has got role in oral pathology. As I'm getting for your question, are we thinking of oral pathological lesions or bony lesions? In case we are thinking of oral pathological lesions like lichen planus or soft tissue lesions, CBCT has got no role because CBCT is not able to provide soft tissue details for those lesions like squamous cell carcinoma, which is in the soft tissues or carcinoma of the tongue. We need to get a CECT, that is contrast enhanced computed tomography, or an MRI, or ultrasound in case it's required. But in case, yes, we are talking about oral pathological lesions which are there in the bone. Yes, CBCT has got a major role. We can diagnose, detect, depict, evaluate all the size, all the adjacent structures and extensions of bony lesions with CBCT. So, in case there is an oral pathological lesion like ameloblastoma or a cyst, we can definitely go for a CBCT without any delay.
Okay, right. We have another one from Professor Hiller. He says, how much information can a CBCT yield on adjacent soft tissues, in particular perineural involvement and soft tissue extension of neoplasms?
Uh, Thank you, Dr. Jones, for this question. Again, the answer is almost similar as I've given to Dr. Muthu, that soft tissue evaluation is a limitation of CBCT. At the moment, CBCT doesn't provide information for soft tissues. It is for the bony counterparts. We have to do CBCT. But yes, in case we are thinking about perineal invasion regarding implants in the inferior alveolar nerve canal, since there is a bony boundary present, like in case we think of inferior alveolar nerve canal, there is superior boundary as well as inferior boundary present. So with the help of those corticated boundaries, we can assume that something is going inside. So neural invasion of implants inside the inferior alveolar nerve is possible because of corticated boundaries. But otherwise, CBCT doesn't yield good information about soft tissues. So I would advise to all practitioners or all the listeners that in case they are advising CBCT for a soft tissue lesion, it's always advisable to get a 2D imaging modality first. Suppose there is a lesion and you are not sure clinically that whether it is involving bone or not. So a part of just asking the patient to go for a CBCT, you can take an IOP or an OPG first. Okay, so in case there is no bony involvement on an IOP or OPG and on clinical examination it is not being justified, then do not ask the patient to get subjected to CBCT because it will lead to undue and unjustified exposure to X-rays and it will hamper our ALARA principle as well. So, just for hard tissues, in case we know, we should go for a CBCT scan. Otherwise, for soft tissues, it's a complete no.
Okay. So, Dr. Muttu says, thank you. Dr. Krishna is there and she says, agree CBCT is a must have now. Yes, yes.
Great. Yes, absolutely. These days, 3D evaluation when it is possible. Since CBCT has got isotropic voxels. Isotropic voxels means that all the sides of the voxels are together. So it gives 1:1 ratio of measurement. Whatever is there in our mouth, in case it is 1 millimeters, it will be depicted as 1 millimeter on CBCT. So we should take benefit of CBCT in such cases.
Yeah,
And I
that one is to
agree
one
again
ratio
that
is
yes,
really very important. Yes. Because otherwise, typically when we are looking, especially other our X-rays, not forget CT scan, but the typical X-ray evaluation, we almost always get some form of enlargement or shrinking, or basically the size is almost never 1:1. So this is a very good thing that we continue. We can get it as the exact size.
again, I think there is some problem in your
Can
voice.
you
Can
hear
you
me
please
now?
write down? I can
Let
hear
me
you. Can you
see.
please write down the question?
Hello.
Hello, ma'am. Can you hear me?
Yeah, I will do that. Let me put it as a
There
comment.
is some problem with the connection. I feel.
Yeah.
Can you please write down the question in the comments?
Yes.
It will be helpful. Yes, extremely sorry for the bad internet connection on my side. I probably.
Right.
So I'll read your question, ma'am. It is the size as 1:1 is very helpful and something that is not available on other commonly used methods. Absolutely correct, ma'am. Sorry for inconvenience that you had to type that question.
That's okay.
But yes, this is a very
Hmm.
beautiful imaging modality which gives the size of the bony lesions in 1:1 ratio. That means in case it is 1 millimeter inside the bone, it will be 1 millimeter depicted on CBCT also, and it
Also.
is not available on any other diagnostic imaging modality except CT. Yes, on CT we can say, although CT has not called isotropic voxels, but yes, CT is possible. But since radiation dosage of CBCT is quite less, 4 to 5 times to 10 times lesser as compared to CT scan, so we should opt for a CBCT scan instead of CT.
Good. That's true.
Otherwise, in case we talk about OPGs and other 2D imaging modalities like an IOPA, they can show distorted images. Sometimes there is magnification, sometimes there is foreshortening. So we cannot truly rely upon, in case we are trying to justify that, during implants or any other surgical procedures where we have to be precise enough in millimeters. So that is why CBCT is must in such cases to know the extensions and even in implants. Am I audible, ma'am?
Yes, you are. You are. You are. You are.
Okay. How CBCT? How is CBCT for judging the lesion borders? Yes, ma'am. Again, a very good question. Yes, CBCT is absolutely helpful for judging the lesion borders in case the lesion borders are corticated. In case we are talking about bone, yes,
Yes.
CBCT will give again a very beautiful picture of those borders. In CBCT, there are so many imaging modalities or software modalities available. In case you let me explain, there are certain kinds of orthogonal views. Orthogonal views are those in which we can divide evaluation of CBCT in three planes: coronal, sagittal, and axial. And there is non-orthogonal planes also possible. So that means we can tilt the direction of the CBCT slice anywhere, and we can evaluate the bony lesion in any direction. So it gives 1:1 and all directional view of the lesion. So CBCT is helpful in judging the lesion borders in a perfectly possible way.
Very nice.
Yes, ma'am.
So, anyone else has any questions, or till then, let me show. So we have good information. And so with us, we have. Let's see who else is with us today. We have Dr. Nagihan. Okay. We have Dr. Sarojini. We have Professor Joss. We have Dr. Ashok Lingappa, Dr. Bhuvan, Dr. Muttu, Dr. Krishna. So these are the people who have typed. People who have not typed, well, we don't know they're there. And
I'm
can you hear
grateful.
me now?
I'm grateful. I'm grateful to
Yeah.
all, especially Dr. Shok sir, for joining the session. Sir is quite senior and is a mentor of mine. So I would
Yes.
say thank you so much, sir, and thank you all the participants for joining. Especially a big thanks for you, ma'am. You gave me the platform for intimating my ideas and my presentation. So really, 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 I'm grateful to you. Thank you so much, ma'am.
You're most welcome. You're most welcome. So it looks like we don't have any more. Dr. Gupta is saying good evening. Well, good evening to you too.
Good evening.
So, okay, let's just bring your certificate.
Thank you.
Yes.
Thank you, ma'am.
Thank you.
Thank you so much.
You are
Thank you
most
so much.
welcome. And it was a pleasure having you here. And I hope you will come back and finish all those parts that you cut out of your lecture. You can take another lecture.
Absolutely, absolutely. It will be a prestige and again an honor for me to join the session. And definitely next time my internet connection probably will be more better. Again, sorry for bad internet connection.
No, that's okay. It happens. Technology, you can't help it. That happens.
Yes, ma'am.
Okay, now
Yes,
this
ma'am.
is where I make announcement about what is happening next week. Just to remind everybody, we are going on to our summer vacations. So, in fact, next week there will be no OP Tuesdays. Please do not turn up and then wonder what happened. Okay, we will be back on the 4th of June. The 4th of June is a Tuesday, and we will be back on the 4th of June. Till then, we are having a, well, summer break. So, with that, and I can see there are no more questions or comments. Thank you, Mr. Madan Raheja. And yep, that's about it. Okay, dokie. So, right. Thank you, everybody. Thank you,
Thank
Dr.
you.
Gupta. And I
Thank you
do
so
hope
much,
you'll
ma'am.
come back soon. And so, everyone,
Absolutely.
I normally say have a nice week. Now I'm going to say have a nice summer. And I will end of May. And we will meet in June. See you all. Bye
Bye.
bye.
Thank you, ma'am. Thank you
Bye.
so much.
Welcome. Bye.